Welcome to Bookfulness. This is episode 14, and we are continuing our deep dive into the structure and really the clinical relevance of the thoracic cavity, using clinically oriented anatomy as our guide.
Yeah, last time we laid out the basics, didn't we? The lungs themselves, the pleural cavities, kind of the fundamental setup for breathing. That was the what.
Exactly. And today, we're shifting gears hard into the so what. Our mission is kind of twofold. First, we really want to get into the clinical side of things for the lungs and pleurae. What goes wrong, injury, fluid, air.
Right, the practical implications, and what procedures we actually do about it.
And then second, we're moving inward, centrally. We're leaving the periphery and heading straight into the mediastinum. We'll map out its boundaries, its structure, and really focus in on the pericardium.
The heart's protective jacket, essentially, a really critical structure.
Yeah, this is where anatomy stops being just lines on a diagram and starts becoming about, well, life-death situations, honestly. Knowing exactly where a nerve runs or why you aim a needle here and not there.
That's the difference between fixing the problem and causing a bigger one. It's anatomy in action, which, let's face it, is where it gets really interesting.
Totally agree. Okay, let's unpack this clinical material. We'll start right at the top edge of the chest cavity, thinking about how vulnerable the pleurae can be and the lungs just beneath them.
Right. So the first thing we absolutely have to highlight is something that, well, it often trips people up. It's this idea of injury to the cervical pleura. You can find the details starting on original page 608.
Yeah, I think instinctively you picture the lungs stopping neatly behind the collarbone, like at the first rib. But that's not quite right, is it?
Not at all. The very top part of the lung, the apex and the pleura covering it. The cervical pleura actually bulge upwards. They poke right through that superior thoracic aperture into the root of the neck.
So they're sitting just above the first rib, kind of deep in that little hollow above the clavicle.
Precisely. And that little upward bulge makes them surprisingly vulnerable. Think about, say, a stab wound high on the chest, or maybe even low in the neck, or maybe a fracture of the clavicle sending sharp bone fragments downward.
Okay, but why is that specific spot, that apex, potentially so much more dangerous than, say, getting hit lower down on the ribs?
It's all about location, location, location. Because right there, crossing just superior to that lung apex, you have a whole bundle of critical structures heading to the arm. And injury penetrating the cervical pleura isn't just risking lung collapse.
Which is bad enough.
Oh, absolutely.
Yeah.
But it could also directly damage the huge nerve, bundle the trunks of the brachial plexus or the major blood vessels, the subclavian artery and vein.
Wow. Okay, so a seemingly localized wound up there could actually lead to massive bleeding if you hit the subclavian artery. Or, I don't know, permanent arm weakness or numbness if the brachial plexus is damaged. The stakes are way higher.
Exponentially higher. It means any trauma in that supraclavicular zone demands a really careful check of the arm's nerve function and blood supply. You have to think about that potential collateral damage because of the anatomy.
Makes sense. Okay, let's move just inside the chest wall then. The big danger to the lung itself, if the pleura is breached, isn't always the wound itself, but the collapse that follows, right? Atelectasis?
That's the term, yes. Atelectasis or pulmonary collapse. Basically, the lung just deflates. It fails to expand properly. Sometimes it's blocked from the inside, like with mucus, but often it's pressure from the outside, from the pleural cavity filling up with something it shouldn't.
And we have specific names for what fills that space, all ending in thorax. Let's quickly define the main three.
Sure. First, pneumothorax. That's pneumo for air. Air gets into the pleural cavity, disrupts that nice negative pressure, that surface tension holding the lung out, and poof, the lung recoils and collapses.
Okay, air, then there's fluid.
Right, hydrothorax. Hydro, for water or fluid. This is usually serous fluid, like plasma leaking out. You often see it with things like heart failure or significant inflammation.
And the third one, the one you really worry about in trauma.
Hemothorax. Hemo for blood. This means the pleural cavity is filling with blood, usually from a torn intercostal vessel, maybe even the lung tissue itself after a major injury. And obviously, telling a hydrothorax apart from a hemothorax is critical. One's about fluid overload, the other is about active bleeding.
Got it. And when you do have fluid accumulating, hydro or hemo, how the patient is positioned really matters for finding it, doesn't it? Where does it typically pool if they're sitting or standing up?
Gravity wins. Simple physics. Any extra fluid in the pleural space is going to sink to the lowest available point. And because the lungs move up and down, that lowest point is usually that deep gutter way down at the bottom and sides, the custodiophragmatic recess.
That little space where the diaphragm meets the ribs.
Exactly, where the parietal pleura lining the ribs reflects onto the diaphragm. That's your collection point.
And knowing that that fluid's pool in the custodiophragmatic recess directly tells us where to go looking for it or where to drain it. Which brings us neatly to procedures. #tag 1.2 diagnostic and therapeutic procedures.
Okay, so the main way we sample or remove that fluid is thoracentesis. You might hear it called a pleural tap. It's described on page 611. Basically sticking a needle into that pleural cavity.
And doing this safely hinges entirely on knowing where not to stick the needle, right? Because of the nerves and blood vessels running along the ribs. What's the absolute rule?
The golden rule, never break it. Insert the needle immediately superior to the rib that marks the bottom of the intercostal space you're aiming for. Never, ever go near the top edge of that lower rib.
Because that's where the bundle hangs out, in that little groove on the underside of the rib above.
Precisely. The intercostal vein, artery, and nerve van, top to bottom, are tucked right into the costal groove on the inferior border of the rib above. If you aim just above the rib below, you stay clear. Go too close to the bottom of the upper rib, and you risk hitting them.
Causing bleeding, nerve pain, making things worse. Okay, so aim high within the space. Now, where exactly? We said fluid collects low down. The book suggests the 9th intercostal space, mid-axillary line, with the patient upright. Why not go even lower, like the 10th or 11th space, if the recess goes down there?
That's a really critical point about safety. Yes, the recess goes lower posteriorly, maybe down to the 12th rib, but clinically, we usually stop around the 9th, maybe 10th space laterally. It's a trade-off. And crucially, you do this during expiration.
Why expiration specifically?
Because during expiration, the diaphragm comes up, and the lower edge of the lung recoils upwards, getting it out of the way. This gives you the biggest gap between the lung and the diaphragm to safely insert the needle into the recess without hitting the lung itself.
Okay, so expiration pulls the lung up. But what about structures below the diaphragm? What's the risk if you go too low or angle the needle wrong?
Big risk. If you go much below the 9th or 10th rib laterally or angle the needle downwards instead of slightly upwards, you risk punching right through the diaphragm. And what's immediately underneath the diaphragm, especially on the right side?
The liver.
The liver. Puncturing the liver is a major complication. On the left, you might hit the spleen or stomach. So the 9th intercostal space, mid-axillary line, angled slightly up during expiration. It's the sweet spot. Access the fluid, avoid the lung, avoid the liver.
Makes sense. Now, what if you need more than just a needle tap? Like for draining a lot of air or blood, like a tension pneumothorax or a big hemothorax. That's when you'd put in a chest tube, right? Is the approach different?
Yeah, a chest tube is much bigger, requires a small incision, not just a needle poke, often done via what's called a posterolateral thoracotomy approach. And the target zone is usually a bit higher and more lateral, often around the 5th to 7th intercostal spaces. That gives good drainage, especially laterally.
And I remember reading the patient's arm position is key here too.
Absolutely. To get the best access to those lateral intercostal spaces, you typically have the patient abduct their arm way up, like putting their hand behind their head. This pulls the scapula, the shoulder blade up and out of the way laterally.
Opens the side of the chest wall.
Exactly. Clears the field, gives you better access to maybe the 4th, 5th, 6th spaces right there in the mid-axillary line. Makes for a safer, cleaner insertion.
Okay, and one last procedure mentioned is thoracoscopy, using a camera to look inside. If a surgeon needs to, say, separate the parietal pleura from the inside of the rib cage, there's a specific layer they use.
Yes, they exploit the endothoracic fascia. This is a thin, kind of loose layer of connective tissue that sits right between the parietal pleura and the inner surface of the chest wall, the ribs, the muscles. Because it's loose, it creates a natural cleavage plane.
Like a built-in separation layer.
Pretty much. Surgeons can get an instrument into that plane and carefully peel the pleura away from the ribs without tearing the pleura itself, which is obviously quite delicate. Very useful for certain procedures.
Fascinating. Okay, we've covered the boundaries and access. Let's dive into some specific pathologies affecting the airways and blood flow within the lungs. #tagged 1.3 pathologies affecting airway and circulation.
Let's start with the blood flow side. Pulmonary embolism, or PE. This is a really common and potentially deadly condition.
Right, this is when a clot, usually starting as a DVT, a deep vein thrombosis in the leg, breaks off, travels through the bloodstream.
Up through the veins, into the right side of the heart, and then gets pumped out into the pulmonary arteries, and then eventually gets stuck, lodged in one of the pulmonary artery branches because it's too big to go any further.
And the immediate result is that a whole section of lung downstream from that clot loses its blood supply.
Correct. And that leads to the classic problem in PE. A ventilation-perfusion mismatch, or VQ mismatch, you'll hear it called. meaning the air sacs, the alveoli in that part of the lung, are still getting air, they're being ventilated, but there's no blood flowing past them. They're not being perfused. So oxygen comes in, but there's no blood to pick it up and carry it away. Gas exchange just stops in that area.
Leading to low oxygen levels, shortness of breath, potentially even tissue death in the lung if it's a big clot. Okay. Now let's switch to the airways, the tracheobronchial tray. The classic problem here is aspiration of foreign bodies. Page 617 has a good figure, B4.14, and the clinical pearl everyone learns is...
It almost always goes down the right side. If someone inhales something, a peanut, a bead, a piece of carrot, chances are overwhelmingly high it's going to end up lodged in the right main bronchus, or maybe even a bit deeper in the right intermediate bronchus.
And there are solid anatomical reasons for that preference, right?
Yeah.
It's not just random.
Not at all. 3 key reasons. 1, the right main bronchus is simply wider than the left. 2 is shorter. And 3, probably the most important, it branches off the trachea at a less sharp angle. It runs more vertically downwards compared to the left main bronchus, which angles off more horizontally because the heart pushes it aside.
So gravity just kind of funnels things down the right path more easily.
It's basically a straight shot down the right side.
Now, what about the carina? That ridge right at the bottom where the trachea splits?
No, the carina. It's covered in supersensitive mucous membrane. If that foreign object hits the carina on the way down, it triggers a massive, violent cough reflex. Sometimes that's enough to expel it.
But not always.
Right. And here's the tricky part, clinically. If the object manages to get past the carina and settles down into the right bronchus, that intense irritation often stops. The patient might stop coughing suddenly.
Giving a false sense of security.
Exactly. They stop coughing, maybe feel okay for a bit, but the obstruction is still there, now lodged deeper, potentially causing problems like pneumonia or lung collapse later on. That silent period after passing the carina can be misleading.
Definitely something to watch out for.
Mm-hmm.
Okay, let's tackle the big one, lung cancer or bronchogenic carcinoma. Specifically, how it spreads metastasis.
Yeah, lung cancer unfortunately tends to spread early and often follows predictable routes. Lymphatic spread is very common, initially to the local nodes near the bronchopulmonary nodes, then the nodes at the lung root, the hilar nodes.
And then upwards.
And then often upwards to the lymph nodes above the collarbone, the supraclavicular lymph nodes.
Weren't those sometimes called sentinel nodes?
Historically, yes, especially for cancers in the chest or upper abdomen. If you could feel enlarged, hard nodes in that supraclavicular fossa, it was often the first sign, the sentinel, that cancer had spread from deeper inside, even if the primary tumor wasn't causing symptoms yet.
But there's another really insidious way lung cancer spreads, isn't there? Through the veins, especially to bones in the brain. Can you explain the role of the internal vertebral venous plexus?
Ah, yes, Batson's plexus. This is a fascinating and clinically crucial pathway. Cancer cells can get into the posterior intercostal veins. These veins drain the back of the chest wall, but they also have connections, direct connections to this network of veins surrounding the spinal cord, the internal vertebral venous plexus.
And what's special about this plexus?
The key thing is that it's largely valveless. There are few, if any, functional valves preventing backflow. So anything that increases pressure inside the chest or abdomen, like coughing hard, straining, even just changing position, can cause blood to flow backwards through these connections.
So the cancer cells don't necessarily go through the main circulation filter of the liver or lungs?
Exactly. They can bypass that main systemic route and get shunted directly up the vertebral column towards the skull or down towards the pelvis. It's a direct route for metastasis to the vertebrae, the cranium, and the brain.
That explains why bone mets are so common in lung cancer. And other cancers like prostate too, right? It's a venous highway for spread.
A very effective, unfortunately, highway.
Yeah.
And speaking of signs, there's one more related to cancer spreading locally, especially relevant for female patients, the involvement of the chest wall muscles.
The pectoral muscles.
Yes. If the cancer invades through the chest wall and gets into the pectoral fascia, or that space behind the breast, the retromammary space, it effectively tethers the breast tissue down to the underlying muscle.
And how does that show up clinically?
The classic sign is that the breast visibly elevates or dimples when the patient actively contracts their pectoralis major muscle. You test this by having them press their hands firmly onto their hips and push their elbows forward. That tenses the pecs. If you see the breast lift unnaturally, it's a strong indicator of deep fascial invasion by the tumor.
Wow. Okay, so we've really mapped out the clinical hotspots around the lungs and pleurae, from that dangerous neck apex down to the recesses and the pathways for clots, foreign bodies, and cancer. Now it's time to move deeper.
Into the central core, the mediastinum.
All right, let's define the mediastinum. Fundamentally, what is it? It's that central block of tissue, right? Separating the two lungs.
Exactly. It's a central partition in the thoracic cavity. Think of it like the thick wall dividing two rooms, the rooms being the pulmonary cavities containing the lungs. It runs from the sternum at the front to the vertebrae at the back.
And laterally, its walls are just the mediastinal pleura of each lung.
Correct. Sternum anterior, vertebrae posterior, mediastinal pleura on the sides. And superiorly, it goes up to the thoracic inlet, inferiorly down to the diaphragm.
Now, to make sense of all the structures packed in there, anatomists divide it up. And the key dividing line is that imaginary plane, the transverse thoracic plane.
Yes, probably the single most important landmark plane in the thorax. You draw it from the sternal angle, that palpable bump where the top part of the sternum meets the main body.
Angle of Leo.
Right. Draw a line from there, straight back to the intervertebral disc between the T4 and T5 vertebrae. Everything above that plane is the superior mediastinum. Everything below it is the inferior mediastinum.
Okay, T4, T5. Why that specific vertebral level? Is it just arbitrary, or does something important happen there?
Oh, it's far from arbitrary. That T4, T5 level is a major crossroads. It's where the trachea bifurcates, splits into the right and left main bronchi. It's where the arch of the aorta begins and ends. It's roughly where the superior vena cava, SVC, pierces the pericardium to enter the heart. The azygos vein arches over to drain into the SVC there too. It's a huge transition point.
Gotcha. So that plane divides it into superior and inferior. Then that larger inferior mediastinum gets divided further based on the biggest thing sitting in it, the heart.
Right. The heart and its covering, the pericardium, sit squarely in the middle of the inferior mediastinum. So they define the middle mediastinum. The space in front of the heart and pericardium between them and the sternum is the anterior mediastinum.
Which is pretty small, right? Mostly fat, some lymph nodes.
Yeah, not much in there usually. And then the space behind the heart and pericardium between them and the vertebrae is the posterior mediastinum.
And that's where you find things like the esophagus, the descending aorta, the thoracic duct.
Exactly. But for now, our focus is shifting right to that central engine block, the middle mediastinum.
And its main contents are basically the heart, its protective sac, and the very roots of the big pipes coming in and out.
That's it. The heart, the pericardium surrounding it, and the beginnings of the great vessels, the ascending aorta, the pulmonary trunk splitting off, and the SVC coming in. That's the core package. Hashtag 2.2 anatomy of the pericardium.
Okay, let's really zoom in on the pericardium now. Page 624 starts the detail. It's described as a fibroserous membrane. So two parts to that name.
Right. Fibro and serous. Let's start outside in. The outer layer is the fibrous pericardium. This is the fibro part. It's a really tough, dense, connective tissue sac, cone-shaped, fitting snugly around the heart. And crucially, it's inelastic. It doesn't stretch easily or quickly.
But that lack of stretchiness sounds protective, but maybe problematic too.
Exactly. We'll definitely come back to the problems it causes. But structurally, it's strong. And it's not just floating there, it's anchored down.
How so?
Inferiorly, the bottom of the fibrous pericardium fuses completely with the central tendon of the diaphragm. It's directly attached. So when you breathe and your diaphragm moves, the heart moves slightly with it. This anchors it.
Okay, that's the tough outer shell. Inside that is the issus pericardium, the serous pericardium. This sounds like the pleura again.
Very similar principle. It's a thin, double-layered membrane made of that slippery mesothelium. It has two parts. The parietal layer, which lines the inner surface of the fibrous pericardium.
So it's stuck to the inside of the tough sac.
Right. And then there's the visceral layer, which is stuck directly onto the surface of the heart muscle itself. It is the outer layer of the heart wall.
And that visceral layer has another name too, right?
Yes. The visceral layer of the serous pericardium is also called the epicardium. Same thing. Epi meaning upon, cardium, heart. It's the outermost layer of the heart.
So where do these two serous layers, parietal and visceral, meet or become continuous?
They become continuous where the great vessels pierce the fibrous pericardium to enter or leave the heart. So around the aorta, pulmonary trunk, SVC, IVC, pulmonary veins, the parietal layer reflects off the inside of the fibrous sac and folds back onto the heart surface to become the visceral layer epicardium.
Like folding a sheet back on itself. And the space between those two folded layers is the pericardial cavity.
Correct. It's normally just a potential space. It contains only a tiny amount, maybe 15 to 50 milliliters of thin serous fluid, just enough to act as a lubricant.
so the heart can beat constantly without rubbing and friction.
Exactly. That fluid allows the epicardium, visceral layer, to glide smoothly against the parietal layer lining the sac with every single heartbeat. Minimizes friction, allows free movement. Hashtag 2.3, the pericardial sinuses.
Now, the way that serous pericardium reflects around those big vessels isn't just a simple fold. It creates these specific pockets or recesses called the pericardial sinuses. There are two main ones, right? Page 626 has figures.
Yes, the transverse pericardial sinus and the oblique pericardial sinus. They're basically spaces within the pericardial cavity formed by those complex reflections around the vessels during development. But they remain as important anatomical landmarks.
Let's take the transverse sinus first. Where is it and what does it separate?
Okay, the transverse sinus is like a tunnel or passageway that runs horizontally or transversely behind the big arteries leaving the heart.
So, behind the aorta and pulmonary trunk.
Exactly. It runs posterior to the ascending aorta and pulmonary trunk, but anterior to the big veins coming in the SVC, IVC, and pulmonary veins. It separates the arterial outflow tract in front from the venous inflow structures behind.
A tunnel separating arteries from veins. I can already see how that might be useful surgically. We'll definitely come back to that. What about the other one? The oblique pericardial sinus.
The oblique sinus is different. It's not really a passage through. It's more like a blind-ended pouch or cul-de-sac. It's located on the posterior side of the heart, behind the left atrium specifically.
A dead-end pocket at the back.
Pretty much. It's formed by the reflection of the serous pericardium around the veins entering the heart, posteriorly, mainly the pulmonary veins, and the inferior vena cava, IVC.
So unlike the transverse sinus, you can't really pass anything through the oblique sinus.
No, it's a blind alley. Its main relevance isn't so much surgical access, but more as a space where fluid might collect if there's a pericardial effusion. It's just this recess tucked behind the heart.
Okay, that gives us the blueprint. Tough outer bag, slippery inner lining with lubricating fluid, and these two specific sinuses formed by the plumbing connections. Now, let's get clinical again. What happens when things go wrong with this container?
And this is where that inelastic fibrous pericardium really becomes a central player in pathology. Its strength becomes a liability.
All right, part 3. Let's start with a really common clinical challenge, chest pain. How do we tell pericardial pain apart from, say, heart attack pain? It comes down to nerves, specifically the innervation of the pericardium in referred pain.
This is absolutely key. The layer of the pericardium that feels sharp pain is the parietal layer of the serous pericardium. The lining stuck to the inside of that tough fibrous sac, and the nerves supplying it are the phrenic nerves.
Okay, phrenic nerves. Remind us where they come from.
The phrenic nerves originate high up in the neck, from spinal cord segments C3, C4, and C5. Keep C3, 4, 5 in mind.
C3, 4, 5, keep the diaphragm alive and feel pericardial pain.
Exactly. But importantly, those same spinal segments C3, 4, 5 also supply sensation to the skin over the shoulder and the supraclavicular area, that hollow above the collarbone.
So when something irritates that parietal pericardium-like inflammation and pericarditis.
Pain signals travel back up the phrenic nerve to the C3, 4, 5 levels of the spinal cord. Now, the brain is used to getting signals from the skin of the shoulder via C3, 4, 5. So when this signal comes in from the pericardium via the phrenic nerve,
The brain gets confused and thinks the pain is coming from the shoulder.
Precisely. It refers the pain to the dermatome supplied by C3, C5. So the patient complains of pain in their shoulder tip or neck area, even though the problem is deep inside their chest around the heart.
That's critically different from heart muscle pain, right? Myocardial pain.
Totally different. The heart muscle itself gets visceral sensory nerves, which primarily sense ischemia, lack of oxygen, leading to that crushing deep substernal pressure or ache. Pericardial pain from the parietal layer via the phrenic nerve tends to be sharper, more localized, though referred, and often worse with breathing or lying down. That difference in pain quality and location is a huge diagnostic clue.
Very important distinction. Okay, shifting from nerves to mechanics. How does just plain old gravity affect where the heart sits? The source mentions posture. Figure B4.20.
Yeah, because the pericardium is fused to the diaphragm, the heart's position changes quite a bit between lying down and standing up. When you're supine lying flat on your back, your abdominal organs push the diaphragm upwards.
Pushes everything up.
Right, which pushes the heart and the whole mediastinum up to its highest position in the chest.
And when you stand or sit up,
Gravity pulls the abdominal organs down, the diaphragm descends, and the heart and mediastinum sit low in the chest cavity.
and this has real implications for breathing, especially for people who are already struggling, right? Patients with dyspnea, difficulty breathing.
Absolutely. You almost always see patients with severe shortness of breath, wanting to sit bolt upright, maybe leaning forward on a table, the tripod position. They instinctively avoid lying flat.
Why does sitting up help so much?
Two main reasons. First, gravity helps pull the diaphragm down when they inhale, making the work of breathing a bit easier. Second, and maybe more importantly, by letting the diaphragm descend fully, it increases the vertical volume of the chest cavity. This increases their functional residual capacity, basically.
Yeah.
The amount of air left in their lungs after a normal breath out. It gives them more reserve.
So just mechanically makes breathing more efficient when they're struggling.
Exactly. Less effort, more lung volume available. It's why forcing someone with severe dyspnea to lie flat can be dangerous. Hashtag 3.2 pathologies of the pericardial space.
Okay, let's talk about things going wrong within that pericardial sac. First up, inflammation, pericarditis.
Pericarditis just means inflammation of the pericardium. Can be caused by infections, viruses are common, or sometimes after a heart attack or other inflammatory conditions. The key result is that those smooth serous layers, the parietal and visceral epicardium, get rough and inflamed.
And when those rough layers rub against each other with each heartbeat, what do you hear?
You hear the classic pericardial friction rub. It's a very distinctive sound through a stethoscope, high-pitched, scratchy, almost like leather rubbing together or walking on dry snow. It comes and goes with the heartbeat. Hearing that rub is pretty diagnostic for pericarditis.
And it usually causes chest pain too, often that sharp pleuritic kind, maybe referred to the shoulder.
Hmm.
Now, what if that inflammation leads to fluid building up in the pericardial cavity? Not blood, but inflammatory fluid or pus. That's pericardial effusion.
Right. Effusion just means excess fluid in that potential space. If it builds up slowly, the body might cope for a while. But remember that inelastic fibrous pericardium, it can't stretch much.
So the pressure inside the sac starts to rise.
Exactly. As fluid accumulates, the pressure inside the pericardial sac increases, squeezing the heart from the outside. This makes it harder for the heart chambers, especially the thinner-walled atria, to expand and fill properly during diastole.
Less filling means less blood pumped out.
Precisely. Cardiac output starts to drop. This can lead to fatigue, shortness of breath, swelling.
And if that fluid builds up really fast, or if it's blood accumulating rapidly, say from trauma,
Right.
that's the emergency. Cardiac tamponade.
Tamponade is the acute, life-threatening version. Think of a stab wound to the heart. Blood pours into the pericardial sac very quickly. That inelastic fibrous sac can't expand fast enough to accommodate the volume.
So the pressure skyrockets instantly.
Instantly. And that extreme pressure completely crushes the heart. It prevents blood from returning to the heart via the veins. Venous return collapses and makes it impossible for the ventricles to fill.
No filling, no pumping.
No cardiac output. The blood pressure plummets. This is Beck's triad, often low blood pressure, muffled heart sounds because of the fluid, and distended neck veins because blood can't get back into the heart. It requires immediate drainage to relieve the pressure. Surgical emergency, hashtag 3.3, surgical relevance, and pericardiocentesis.
Which brings us to procedures. We mentioned the transverse pericardial sinus earlier, that tunnel behind the aorta and pulmonary trunk. How do surgeons actually use that space?
It's incredibly useful, especially in open heart surgery, like coronary artery bypass grafting, CABG. Often the surgeon needs to temporarily stop the heart or control the blood flow coming out of it.
And that sinus gives them access.
Exactly. Because the transverse sinus runs behind the aorta and pulmonary trunk, but in front of the SVC, the surgeon can carefully pass a finger, or more likely a surgical clamp or a vessel loop, right through that space.
So they can physically get around those two big arteries.
Yes. They can pass a tape or clamp through the sinus, encircling the base of the aorta and pulmonary trunk. This allows them to put a clamp across those vessels, an aortic cross clamp, to stop blood flow out of the heart, or to infuse cardioplegic solution directly into the aorta to stop the heart safely.
Wow. So that little anatomical tunnel becomes a critical handle for controlling the major outflow during surgery.
It really does. Turns anatomy into a surgical tool.
Okay. And the procedure to drain fluid, especially in tamponade, is pericardiocentesis. How is that typically done, say, in the ER without opening the chest? The source shows the approach on page 632, figure B4.22.
The common bedside approach, especially in emergencies, is the infrasternal or subxiphoid approach. The patient's usually propped up a bit, maybe 30, 45 degrees.
And where does the needle go?
You go just to the left of the xiphoid process, that little pointy bit at the bottom of the sternum, right in that angle between the xiphoid and the costal margin. You insert the needle there.
Aiming where?
Aiming upwards towards the left shoulder generally and slightly posteriorly. You're aiming for the pericardial sac.
Now, why that specific spot? Why not go between the ribs lower down? It seems like you're going underneath the rib cage.
You are, and the reason is to avoid the lungs and pleura. This approach targets the bare area of the pericardium.
The bare area.
Yeah, remember how the pleura reflects off the chest wall? On the left side, near the sternum, the pleural reflection takes a bit of a detour laterally, leaving a small area where the fibrous pericardium is directly behind the chest wall, around the 5th, 6th intercostal spaces near the sternum and just below the xiphoid, without any pleura or lung tissue in between.
Oh. So by going in just under the xiphoid and angling up, you're aiming for that spot where there's no lung or pleura in the way.
Precisely. It allows direct access to the pericardial sac while minimizing the risk of puncturing the lung, causing a pneumothorax, or lacerating the pleura. It's a much safer window, especially when you need to get in quickly.
That's brilliant. Using a small anatomical window to get to the target safely. Applied anatomy at its best.
Couldn't say it better myself. #tag outro.
Wow. Okay, we have covered a ton of ground today.
Right.
Really moving from the edges of the thorax, the lungs and pleurae, right into that central compartment, the mediastinum, and zeroing in on the pericardium.
Yeah, and focusing on the clinical side, how things like the asymmetric bronchi make aspiration predictable, or how that tough, inelastic, fibrous pericardium, normally protective, becomes dangerous in tamponade.
And the procedures, too, thinking about nerve bundles during thoracentesis, using that bare area for pericardiocentesis, and even how referred pain from the phrenic nerve points you towards the pericardium via the shoulder.
So if we connect this to the bigger picture, we've really established the house for the heart, the mediastinum and pericardium, and highlighted the clinical issues that arise from that housing itself.
Absolutely. In this deep dive, we've hit key clinical points for lungs and pleura, outlined the mediastinum zones, and really dug into the pericardium, its layers, those sinuses, and critical problems like pericarditis and tamponade.
Which leaves us with a final thought for you, the learner. We know the parietal pericardium gets sharp referred pain via the phrenic nerve, C3-C5. We also know the heart muscle itself feels pain differently, more of that deep, crushing, visceral pain related to ischemia.
So consider this. How might a patient's description of their chest pain, sharp versus dull, localized versus crushing, worse with breathing versus constant, help you differentiate between pain originating from the inflamed pericardial sac versus pain from the heart muscle having an actual heart attack? How does that differential innervation translate into the patient's story?
Something to really think about, how the nerves dictate the symptoms.
Definitely food for thought. Okay, next time we finally get inside the house, we open the pericardial sac and explore the heart itself, chambers, valves, the coronary arteries supplying it, the great vessels connected to it. We finally meet the engine.
Looking forward to it. Thanks for tuning in to Bookfulness.
Thanks for listening.